Did you guys know that a court can order you to undergo a C-section? And not just a C-section, but can order you to undergo any form of treatment it deems necessary?
Real judge, you know? Yes, yes. I wasn't being hyperbolic. It's a real judge. Let me get the. Nah, this is the craziest thing I ever seen. Good
Good
morning.
afternoon, ma'am. I know you may be able to see me on your screen in just a second here. I'll introduce myself. I do see you on. Um, can you hear me okay, ma'am?
Oh, yes, sir. I can hear you perfectly fine.
And what's really interesting about this is that there is precedence for this. These recent cases are not the first, and even though these overall incidences are rare, they are becoming a little bit more common and perhaps warrant our attention. What seems to be an erosion of women's autonomy when it comes to pregnancy specifically, but you don't see this erosion in any other area of medicine with any other group of patients. These cases are extremely alarming, and I'm going to walk you through why you should think even beyond just the C-sections and what these cases may actually implicate as to what the direction is for the US when it comes to patient autonomy and when it comes to what is considered to be fetal personhood. So these particular two cases that I'm going to focus on today occurred in Florida. And what's interesting about Florida is that Florida is the state that has the highest rate of these court mandated C-sections. Let me also remind you that Florida is also the same state that has been working on expanding patient medical decision freedoms. And I'll give you two examples. One, Florida has weakened and loosened a lot of the laws when it comes to vaccines and the administration of vaccines for children, removing the mandate of vaccination and also reducing the mandates when it comes to fluorinated water. Why I bring those two things up in particular is the argument for the mandated C-section is the fact that the state feels that it has to make decisions in the best interest of the child. And at the same time, when it comes to vaccinations, the state says that the parents should be allowed to make the decisions when it comes to the welfare and the best decisions for the child. The same mother is being challenged with her autonomy in making decisions with regards to the safest mode of delivery and perhaps other aspects of maternal health care. But that same mother, once the child is here, the rules suddenly change, and that mother now has the authority to make decisions when it comes to vaccines with regards to her child. Now, vaccines, from a public health perspective, a child not receiving a vaccine can potentially put at risk other children when it comes to very highly contagious childhood infections. And so the logic of the welfare of the child seems to not transcend all scenarios, only scenarios when it pertains to pregnancy. Now, to be clear, these women are mentally competent. In fact, one of the patients that we will focus on today is a doula and was a doula at the time. So you're talking about an experienced, well-informed patient who very much understood her rights and understood the context of the decision making she was supposed to be allowed to make. But her decision making and autonomy was overridden by the hospital via the state. Now let's get into those stories.
The last time you were at one of these carpets, you made a lot of headlines, okay? Talking about the wedding has happened. Did you think that that would blow up the way that it did?
I think the weather is really amazing today. It's so sunny. It's a little warm, but it's beautiful. There's no rain, It's beautiful.
So, you guys, before we get into these stories, because we're going to go very deep on this discussion today, because there are so many other subtopics that are equally important to discuss beyond just the court mandated C-sections. It's what it is really saying and why certain subgroups of the population of pregnant persons may, in particularly, be most alarmed with regards to this particular trend. But before we do that, first, I want to welcome all those who are visiting our platform for the very first time. Give yourself a round of applause. And also thanking those who have been with us and have been riding through with us. Give yourself an applause. In fact, if you've been on this platform for 2 years, 3 years, make sure you let us know in the comment because we want to personally thank you for being such a great and amazing supporter. I am Dr. T, and I'm a board certified OBGYN. I'm also a health coach and the founder of HBC. And I am ready to discuss these cases with you guys today because I have plenty to say. Let's get into it. Now, what has led us here has been the ongoing debate about a mom's autonomy over her own body and fetal personhood. And the definition of fetal personhood varies from state to state, which then sort of dictates the direction of the laws. Now, with regards to fetal personhood, one of the biggest debate has been when does the personhood begin? And each state has its own definition, which has led to some of the recent laws when it comes to ABs. Now, this discussion in particular is not going to be focusing on ABs. That's a separate conversation. But clearly, we all know that there has been a huge, drastic shift when it comes to maternal health and pregnancy-related autonomy since the reversal of Roe versus Wade. And as you guys know, since that overturned decision by the Supreme Court, there has been a domino effect across the entire country. And now there continues to be challenges on the state level with a variety of laws that continue to challenge the argument or address the argument of patient autonomy versus fetal personhood. So in every other situation, the patient has full autonomy once they are deemed competent. If they're not deemed competent, that's a different set of rules. But the minute a patient is deemed competent, they have the right to refuse treatment, to deny treatment, to refuse admission to the hospital. The only exception to that is during pregnancy. So in 1986, Minnesota became the first state to deem a fetus a potential victim of a homicide. Over the years, you have had other laws, such as states that have imprisoned women as a result of exposure of the child in utero to drugs. You also have states like Alabama that has expanded the definition of fetal personhood to conception. And so personhood for that particular state can include a frozen embryo. In over 30 states, there are laws that allow hospitals to override the advance directive of a pregnant patient. Now, and most recently on this channel, we have also talked about the case of Adriana Smith. The hospital utilized the legal system to require the ongoing gestational carrying of her son. Now, in that particular case, she was utilized as an incubator. I'm not aware that she had advanced directives, but she certainly had family members who were next of kin who were not allowed to make medical decisions on her behalf. And so that also is an expansion of how this ongoing debate actually is carried out in a variety of circumstances. Now, interestingly, also in Georgia in the early 1980s, a hospital won a court order to force a woman to have a C-section for a pregnancy that was considered to be dangerous. Then also in 1987, a judge in Washington, D.C. approved the request for a surgery for a mom that was dying of cancer. Now, later, a higher court reversed that ruling and held that the hospital should not have overrid the medical decisions. Now, An Illinois appellate court in 1993 refused to order a woman to undergo a C-section. So you're seeing a diversity of rulings when it comes to state level courts. Now, here's an interesting case that I think says a little bit more than just the courts ordering a mandated C-section for someone who's an active patient in the hospital. And this particular case, this other case that happened also in Tallahassee, Florida, in which a patient, Laura Pemberton, did not want to have a C-section. So she did what a lot of patients tend to do when they are um, extending or when they are activating their autonomy, they will leave against medical advice. Now, people leave against medical advice for a variety of reasons. Social reasons, they got to get home, they have childcare issues, they understand the risk of leaving the hospital, but because of their circumstances, they either have no other choice but do not deem the hospital care necessary. Now, in the case of Laura Pemberton, she did not want to have her C-section, so she exercised her right to refuse medical treatment, and she actually left the hospital. Now, a local judge in Florida then sent law enforcement to her house to bring her back to the hospital. When she returned to the hospital, guess what happened, you guys? The judge ordered her to have the C-section, which the doctors then carried out. She later sued the court and lost. The 1999 decision by the federal district judge found that the state had the right to override her wishes. So that was another interesting case because in that particular scenario, it shows that because the hospitals then are under the jurisdiction of the state, and the states are the ones that are bringing the case before the courts, then leaving the hospital does not limit the power of the state or the judge to enforce law enforcement to then bring somebody back to the hospital, which was very alarming because I think for most of us, when we think of sort of the jurisdiction of the hospital, you would think that once you leave the hospital, that the hospital no longer has that particular right over the individual. And so here's another case that was really interesting for a different reason, but again highlighting some of the messaging that these cases are really saying to women across the nation. So in 2009, Samantha Burton had arrived at the same hospital and she was 25 weeks pregnant. After going into preterm labor, the doctors told her that she needed to be hospitalized as an antepartum patient for ongoing management. Now, the hospital, she wanted to leave to go home to her children. And again, we do not know in this ProPublica article, it is not clear as to why she wants to go home to her children, but we all know that childcare, another sick child or a child that has special needs, are some of the very common reasons why women may choose to leave a hospital to go home, even putting their own medical care at risk. Whatever the underlying reason was, you would think that she has the autonomy still, even if you don't agree with her decision making, to enact her own right to leave the hospital. So she wanted to go home to her children. The hospital got a court order to make her remain in the hospital. And guess what happened, you guys? She underwent treatment doctors deemed necessary to save the fetus. They performed an emergency C-section, and the baby was a stillborn. Now, I have lots of questions about that because how did we not know the baby was a stillborn? Or at what point did we realize the baby was a stillborn? At what point was the baby evaluated for viability? It's just lots of questions, but nonetheless, what happened as a result of that case, Samantha Burton then appealed the ruling, and she actually won the appeal. Now, that particular Florida appeals court determined that the appeal was in her favor based on the fact that they said that the circuit judge who made the original decision, should have really evaluated the viability of the baby in making the first ruling. So her winning the appeal had nothing to do with her autonomy. It had everything to do with when and who was responsible for assessing the viability of the pregnancy. So that brings us back to Doula Sharice. And I specifically say Doula Sharice, which is her title, because I want to make sure that we continue to emphasize the point that this was not an incompetent person. This was not someone who is not medically clear. This was someone who was not only medically clear, this was someone who was medically well informed. This was someone who is very familiar with the practice of obstetrics and was very familiar with the circumstances that was being discussed with her healthcare team. So, Doula Sharice had 3 prior C-sections, one of which was complicated by hemorrhage reportedly. And because of her prior experiences, she wanted to undergo a vaginal birth after a prior C-section or a trial of labor after a prior C-section. Those are 2 terms you will hear very commonly in obstetrics. The first one is the VBAC, and the second one is TOLAC. Now, because she had those prior experiences, she wanted to undergo a trial of labor. Reportedly, the obstetricians were concerned about the risk of rupture. Now, granted, uterine rupture in obstetrics is probably one of the most catastrophic outcomes ever. Okay, so you are talking about, when you talk about urgent delivery, we're talking about getting to that uterine rupture as quickly as possible, because as I've shared with you guys on this platform, there is a huge volume of blood going towards the uterus during pregnancy, and so it literally takes minutes for a mom to bleed out. A uterine rupture can lead to severe complications and unaliving for both mom and baby. So we're talking about a very serious and dangerous obstetrical outcome. So it's probably one of those outcomes similar to like shoulder dystocia, where there is a level of heightened alert and concern, and lots of effort is made to sort of select the right candidates for a VBAC or TOLAC. And when I say select, I mean as a joint decision between both the clinician and the patient. Ideally, that's what's supposed to happen, right? Discussing the details of the prior C-sections, the current medical status and condition of the patient, the pelvic structure of the patient's pelvis, meaning making sure that there's nothing inherent about the pelvic structure or the woman's pelvis that can impede the ability to give birth vaginally. Making sure that the baby is a good candidate for delivery, whether you're talking about the estimated size of the baby, making sure that there is no obstructing mass like fibroids that could be getting in the way of the baby getting through the birth canal, or perhaps a tumor on the baby also that can be obstructing the ability to go through the birth canal. So that being said, there's lots of consideration. There is no one size fit all, though I know many of my colleagues use a VBAC calculator. Some of us are concerned about that calculation because of the concern for previously implicit bias. And I'm not going to get into that discussion. We had that discussion before. So make sure you hit up our previous videos. Now, it is understandable that this discussion may be of great concern. And the other aspect of the discussion that you have to keep into consideration is also the skill set of the clinician, right? Now, in general, obstetricians are trained and are tested and are vetted to make sure that we are competent with our skill sets, right? Um, but also there are different scenarios that may challenge the basics, our standard skill sets. And I'm going to get into that in a little bit. So, understanding whether or not there's something about that patient that may be prohibitive, either based on the care status of the hospital, based on availability of additional services, if it may be perceived as a potential complicated C-section. So, you want to make sure your doctor is skilled, you want to make sure that the hospital is equipped. And if there is a concern for either, then I would say that that's probably not the right hospital for the patient to be delivering. And perhaps that should have been the discussion. Also, I'm going to get into discussions that should have been had before this particular scenario. But nonetheless, here is doula Sharice in the midst of her labor process. And instead of receiving additional support, knowing how complicated this particular scenario could have been, or that this perhaps was her first trial of a vaginal delivery. I don't know the details of the decision making with her prior C-sections, but let's assume that this perhaps either was her first delivery or she was going through a labor process after having 3 prior C-sections that would have made her concerned. So instead of receiving additional support, in come a charge nurse with a tablet. And on that tablet was a number of individuals she was asked to cover up before the tablet was placed in front of her. And on the screen was a number of hospital staff, lawyers, doctors, and a judge, Judge Michael Khalil. Well, Judge Michael Khalil made the decision that doula Sharice should undergo and be mandated to have a cesarean section against her will. Now, this was not the first time. There is also a similar case that occurred not that long prior to doula Sharice's experience. Let's also include that in our discussion. So, doula Sharice's experience occurred in September 2004. Now, Brianna Bennett's experience occurred in March 2003, so very close in time frame. And what happened with her case, she too was concerned about the decisions that led to her prior C-sections. And she has a additional concern. And one of the main causes of her concern was that her recovery was very difficult. And her prior recovery was so difficult that she needed assistance for the first couple of weeks after giving birth. What complicated her situation even further was the fact that she had a mom who needed assistance in care. According to the article, it seemed to imply that she was also a caretaker for her mom or would assist her mom. And so it made sense that she would be concerned that given her difficult recovery in the past, that she may then be in need of care herself, but also had the responsibility of assisting her mother. And so she too wanted to undergo a vaginal birth after prior C-section or a trial of delivery after C-section. And after 24 hours of being in labor, she was confronted by a 15 to 20 people entering her room. Now, could you imagine that? 15 to 20 people entering her room with a decision to mandate a C-section. And so she too underwent a C-section against her will. Now let's talk about what all of this really means. So I want to highlight a couple of things about these cases. One, they were both Black women, and I think that's important to say. And it's not because I'm race baiting, nor am I implying that in these particular cases that their race was a factor in the decision made by the judges. I do not have access to know that information, but historically, we can talk about how race may play a role in these scenarios. The first thing that we must acknowledge is the high cesarean rate in the United States. About a third of women undergo C-section. Surveys have been done that have shown about 10% of women have felt that their C-sections were forced on them. We know of a recent article that also exposed in New Jersey that there was a significantly higher rate of cesarean section in Black women. And these higher rate of cesarean sections seem to correlate with the volume of activity in the operating room. Not necessarily saying that they're related, but at least we can observe that there was a correlation between the two. That, of course, enraged a lot of individuals and raised a lot of alarms because the question then again came forth as to whether or not there seems to be bias in the decision making for Black women to undergo a cesarean section. As I discussed that particular topic before, I also highlighted that there have been studies that looked at the healthy Black and Hispanic women, because one of the argument had been that Black and Hispanic women tend to have more complications like diabetes, hypertension, and perhaps those were the leading factors that led to the disparity in the rates of cesarean sections between the two groups. Well, there have been studies that look at the healthy Black and Hispanic women and have found that even among the healthy Black and Hispanic women, meaning those who don't have diabetes, obesity, hypertension, things like that, there still seems to be a persistence in the disparity in the rates of cesarean delivery compared to Caucasian women. So, of course, taking all of this into account, would be very alarming for individuals such as those who are well informed, like Doula Cherise. Knowing this information going into her labor and delivery or going into her childbirth experience, she is probably very well aware of the historic data and disparities when it comes to Black maternal health outcomes in the United States and just maternal health outcomes in general. As mentioned, about 1/3 of women in the United States undergo cesarean delivery. And there has been an effort to decrease that number by giving more opportunities for women to have a trial of labor after a prior C-section. That is where a lot of discordance is coming into place because there seems to be a lot of push and pull between healthcare groups and patients' decisions and autonomy. So there are a number of patients who do question the decision making with their prior C-sections. And I will say there are individuals I have spoken to in a variety of settings that have shared that they in their second C-section, we're not even giving the option or discussion as to whether or not they should undergo a trial of a vaginal birth. And so you do have, with the increased awareness, which is a good thing that women are more aware, you're also having this heightened alertness and awareness of some of these really concerning approach when it comes to the care of minoritized women. Obviously, as much as we talk about race and ethnicity potentially having historical impact or historical effect on some of the decision making, we should also acknowledge the fact that these women were of higher BMIs. And so, as we know, there is also bias when it comes to weight. Now, granted, weight does have outcomes that are more complicated. There's more, which should again be a part of the discussion, right? So, having a C-section when you have a higher BMI, and I'm not sure if uh, what percentage muscle versus body fat they are. I don't have that input. So I'm just going to talk about this from a general perspective. If you have someone who has a higher BMI, the discussion about labor dysfunction is higher, complications to labor are higher, but also so are complications with regards to C-sections. So there are also concerns when it comes to C-sections. There are higher rates of complications. Intraoperatively, you can have higher rates of bleeding, as was already experienced by one of the women in which that was part of her concern. You can have a longer operative time. You may need more instruments, more assistance. And you also and you also can see a higher rate of wound complications, reopened wound, dehiscence wound. We talked about the unfortunate outcome of a midwife, Smith, recently, where her wound reopened. So it's really important that we have a full conversation when counseling patients about their mode of delivery. It is not at all an easy decision. I touched on this a little bit, but I do want to expound on one more aspect to keep into consideration when you are thinking about these cases. Now, With Dula Sharice and with Brianna, I don't know if the clinicians who were caring for their birthing process were also the primary clinicians who are also caring for their antepartum or prenatal care. The reason why I think that's important is because while the current trend has been to have perhaps models where the clinician that is caring for the patient in the outpatient setting isn't also on call and then returns to the office the next day because of the concerns with our proven complications or higher complication rates when there is just extensive work hours. And so you will see a lot of hospitals do a variety of models, and some of those models include an obstetrical hospitalist. So that is a physician who is covering the hospital, who may not necessarily have an ongoing relationship with these clients. And so that may bring into effect an additional factor when it comes to some of these decision making and the comfort level of those types of discussions. So I don't have those details, but I do want to make sure that we also consider that that type of scenario may also be a factor in how much of a trial of labor a clinician may be comfortable with when it comes to patients. And again, that's also another discussion is really what's considered to be a reasonable trial of labor. I don't know whether or not these were inductions also, which can also affect the length of labor. So induction of labor tends to be a longer process than someone who comes in spontaneous labor. So that's also something we should keep in mind. And inductions can take days. And so the question also is, was that a factor? Was also a factor the women had ruptured membranes because that then starts a time clock, increases the risk for infection. Was that a part of the discussion? I do not know those details. So I do want to just bring that to your attention. I am missing that level of insight. And I do think that the answers to those questions can have an impact on the discussion, not really the ultimate discussion as to autonomy, but certainly gaining better understanding as to the circumstances that these women experience. So, how disheartening it is to already know that your labor process may be complicated and not having the support that you need to endure that process. So, I don't know if doula Sharice had a doula who was there, who was present to support her, and the same thing with Brianna, who were their support systems, how much effort was made to prepare them for childbirth, right? I'm assuming that at least doula Sharice may have prepared herself based on her knowledge of obstetrics. But also we have to keep in mind that when we are patients, that we too need a support system. We too need a village. And just even the approach of just without, it seemed like without warning, these women were approached with a judicial system while they were in labor. According to the article, it did not seem that these women were given the heads up or had any time to prepare. So now imagine that you're in the process of labor, which is already a very difficult, the hardest thing to do on earth. I think we're all pretty clear on that, right? So you're doing the hardest thing to do on earth where you really need to focus on what's going on with your child and what's going on with your body. And you are being approached by the judicial system. You are not given support on a legal aspect. You are not given counsel ahead of time, which, just raises some concerns. The fact that a lawyer did not come in to speak with them first, to then go over their rights and to make sure that they had adequate representation in those moments. Representation of an individual that understood their history, understood their perspective, understood their expertise, understood the level of information that they had. So even if they had representation, the question remains how well that representation prepared to defend their case. And perhaps that was a factor in the judge making the decisions that they did. So these are all things that these cases have brought to my thought process. And I hope that as you're hearing about these cases, that you're also contemplating some of these scenarios. But let's talk about sort of the major part of this discussion, and it is the discussion as to why is it that pregnancy seems to be the only group in which autonomy does not apply. And let's talk about the whole concept of who is best to make the decision. So here's the thing. So there is what these cases are essentially saying is that a doctor and a judicial system have the best interest in mind than the mother of the child. These are competent, educated women. We're not talking about scenarios where there's a concern about competency, whether or not they have the mental capacity to make these decisions. These are very well competent, educated women. And yet, the judicial system or the court system of the US has determined that a doctor who may or may not have a relationship with them that's long standing and the judicial system are the best individuals to have the best in mind for a child than the child's mother. Now, here's the thing. The data is very much consistent that the risk of uterine rupture is 1% for a low risk incision on the uterus, 2% for two low risk incisions on the uterus. And the rate on 3 C-sections for uterine rupture is not as clear. We don't have as much data to really be able to counsel effectively on a specific rate like we do for 1 incision or 2 low-risk incisions. But the information that's out there seem to imply that the risk of that is also considered to be low, that the risk of uterine rupture with 3 C-sections also seem to be also very low. And so you would think that it is reasonable for someone to make the decision that I would like to have a trial of labor after having 3 C-sections. Now, doing an urgent surgery can lead to more complications and outcomes. I understand that. I get that. But once the patient is given that information, then it should be up to the patient, given the risk, the alternatives, and the benefits, to be able to make a decision that is best for themselves and their child. Because once that child is out, you give that same mom full autonomy to make all decisions with regards to her same child. The only difference is whether the child is in or out the womb. And that's what's very peculiar about a lot of these decision makings. And a lot of these states that seem to have a direction when it comes to parental autonomy, but seems to blur the line of parental autonomy only when it comes to pregnancy. And so that's one thing I would like us to really consider is, do these doctors really have the best interest in mind? And they may think they do. I'm not saying that they don't. I think that a lot of doctors, I can't say all because there have been some concerning cases, but a lot of doctors really want the best for our patients. However, one of the things that we have been emphasizing in obstetrics recently is the connection of the mom to her body, right? And so, in preparation for childbirth, in the planning of pregnancy, we talk about sort of that intuition that moms have that is outstanding, that is unexplainable to some degree. Um, but moms seem to have an incredible intuition. But also, as we prepare for labor and as women are undergoing the labor process, there is a trend towards helping moms really become in tune with their bodies and know what they feel in their bodies. And that is an aspect of medicine that doctors lack insight on. We are not the ones carrying the child. We are not the ones feeling the process in our bodies. And so it is very peculiar that on one hand, we're encouraging pregnant individuals to be in tune with their bodies and to be aware of their bodies, but then we override when they make decisions based on that insight that they have, which the judges nor the doctors have insight on. And then you expect judges who do not have medical backgrounds in that moment to make decisions on behalf of someone else that they have. And I'm not even going to talk about the dynamics of the race in, in this particular scenario, because I'm sure this incident can happen in other scenarios, but it was striking in the scenario of Dula Sharice that I can't imagine as a Black woman, and I have to bring this up in her particular case, I can't imagine what it feels like as a Black woman to have your autonomy taken away from you, given the historical background of this country, by someone who appears to be a Caucasian male. There are very important dynamics with that scenario that we cannot overlook. Now, that being said, the final comment I would like to make with regards to this very serious issue is, how do we help women in states where this is a more common scenario? So, one of the things you may say, and I really had to think about this again and sort of check my own thought process from before, because when we talk about layers of advocacy, we talk about refusal of treatment, we talk about leaving against medical advice. And the cases that I've shared with you today seem to show that that may not work depending on the state you're in. And so I thought about it some more and I said, well, perhaps this is an opportunity to really emphasize to women to interview their doctors, to choose your doctors wisely. And that seemed at first, when I thought about it, to be a very reasonable approach to addressing these challenges. And then I had to think about the current obstetrical shortages and the current maternity deserts, and realizing that in certain states or in certain communities, there may not be a choice of a doctor or a clinician. And with the growing maternity deserts that we've been talking about, that is becoming more and more of an issue, that women are having less selections, less options. And so choosing your doctor wisely may not, in fact, be a viable option depending on the community that you're in. I also wanted to, I said that was the last, but I got one more. I want to also highlight Brianna's case. So when we talk about social determinants of health, we talk about other things when it comes to our daily living that may impact our healthcare. So in Mrs. Bennett's case, her mom also required help. And so how often in our marginalized communities, we have other responsibilities besides our own children, besides our own healthcare, that also dictates how we make decisions when it comes to our healthcare. And so I do want to highlight the fact that Mrs. Bennett's case also brought up the fact that there was an additional determinant of care, which was her social circumstances, the need to be a caregiver or at least an assistant or supporter for her own mom. And very often in our communities and in our families, the role of a Black woman is also very much multiplicitous. And so very often we have other responsibilities that sometimes dictates our decision making, and impacts our own healthcare. And my question for the hospitals, the judges that made these decisions, Did you also take the same effort in making sure that once the C-section was completed, that these women also received the adequate support that they were already concerned about in their postoperative care? Did you provide support? Did you provide additional services? Did you check in on their mental health, given the fact that I'm sure you're aware that having loss of autonomy can have a significant impact on your own psyche? And so I really do ask, if you were truly concerned about the welfare of the child, how much did you follow up to make sure that the mom received the support she deserved so that she can adequately care for her child that you were concerned about? As she recovered from a C-section she had no intention of undergoing. That being said, this is Dr. T. I hope I have brought some enlightenment to this very serious issue. And I think that not only do these cases highlight a concerning trend in the US, but also the AB cases, the recent case with Brittany Watts. And if you're not aware of that case, I encourage you to make sure that you're informed, because I think that case set precedents for the new case that's happening in Georgia with the filing of, or with the charge of murder for a mom. And if you haven't heard about that, I recommend that you do a search and look into that. But I hope I have opened up your thought process with regards to these cases, or at least brought awareness, because with all that's going on in the world, these cases are being overshadowed, yet they are crucial and very significant when it comes to the maternal health outcomes and the direction of maternal health in this country. And I should say, which I have not said, but I should say that it's important for you to know that the American College of OBGYN do not support court mandated C-sections. There's a concern about just the ethics, the autonomy of patients, and there's a whole write-up with regards to the positioning of the organization. So from a professional standpoint, I can comfortably say that we do not support court mandated C-sections, and we find it highly disturbing and highly concerning as to the direction in which women's health is going. So we have touched on so many related topics, but nonetheless, I'm so happy that you joined us today, because I really do want to bring attention to the experiences of these women. I do not want these cases to go silent when it comes to the media. Thank you for ProPublica for bringing our attention to these cases, and for the courage of the women to speak out and to really go up against a system that historically has not been in our favor. So, that being said, if you want to check out ways to support them, check out the article. I know Dula Sharice has her own Instagram or social media, so go ahead and support her. Follow her so that you can stay updated with what's going on with regards to her experience. And make sure you tap in. We're going to be talking about more of these cases and more of the trends in women's health, so that we can all stay connected and all stay aware, because the decision making in these cases evolve into decision making in other types of cases. So where would this stop? Where would it end? Whose autonomy will be taken away from them? Will it then become other vulnerable communities, like the advanced age community? What other community will have their autonomy questioned or lessened or taken away from them? And so that's why it's important that even if you are not a pregnant woman, that you understand that these cases never stay isolated. They all, if they're allowed to happen, they will evolve into other scenarios, and they will start to impact other individuals. I paraphrase Dr. Martin Luther King Jr.'s one of his most famous quotes, and I'm not going to quote it for verbatim, but it is one of my favorite quote, where it is that injustice anywhere is injustice everywhere. So if we don't pay attention to the injustice that is happening to one group or one individual, and I hope we've learned even in our current circumstances, that injustice eventually expands and will affect you. I am Dr. T, the hand behind the handle of Healthy Bump Club right here on YouTube and Healthy Bump Club on Instagram. I thank you guys so much for joining me today, and I hope to see you guys when on the next episode. Thanks for joining. This is Dr. T, just a friendly reminder. Don't forget to comment, like, and share. And go ahead, why not? Click that subscribe button. Help us to get to the next 1,000 subscribers. We thank you guys for supporting.